Hello everyone, today I'm going to be talking about the percent chance of re-tearing your ACL when you return to sports after surgery. My name is Jordan Simpson and I am a senior in our athletic training program at the University of Mount Union. First, I just want to talk to you about why I conducted this research. For athletic training, we're required to write a 20-page research paper, and I was very interested in this topic because I tore my ACL in high school and I wanted to kind of see what the background information is like and if I ever had a high percent chance of tearing ACL whether I played a sport or not anymore. So a little bit, my paper outline is a claim which states what I wanted to find within my research, the background, why I wanted to conduct my research, an introduction of my research, some evidence which includes anatomy, mechanism of injury, evaluation, imaging, treatment, and a prevention technique. Also an inclusion criteria, which is where I found a lot of my resources in academic journals. Limitations, which states why my study was a little limited, and conclusions, and then my works cited. So my claim was high school female athletes that have surgery to repair their damaged anterior cruciate ligament have a high percent chance of re-tearing their ACL after they return to play. Next is my background, so I already told you a little bit about it. I really was interested in this research and this topic because I as well tore my ACL and I never re-tore it, but I did want to kind of see the chances of what it would be like if I could re-tear it, or as I am an athletic trainer, I've had a couple girls tear their ACLs, what the chance of them re-tearing would be as well. So a little bit about this is I wanted to do this to educate others on ACLs and how you can tear and re-tear an anterior cruciate ligament. It also helps to fill the gap in research right now with this subject, and it addresses the possible causes of initial and secondary ACL injury, explores rehab preventative methods, and also I think that this information is beneficial to coaches, athletic trainers, and physical therapists because this is such a common injury and it's so widespread. It happens all across the world. So the first thing is my introduction. I use many scholarly and position statements, scholarly journals and position statements, and there were a lot of trials that I researched, and they did provide a lot of evidence to support my claim. But the statement that stuck with me the most was stated by Meyer and his colleagues in 2015. It was that 11% of reconstructed ACLs did not last longer than 15 years. And 1/3 of those athletes that returned to participation did in fact re-tear their ACL, and 30% of them were within the first 20 athletic events, which means it could have happened during practice, it could have happened during a game, it could have happened during jump stretch or even lifting. The first 20 events, I actually knew a girl who tore her ACL within the first 5 minutes of being back on the court after she got released to play basketball again. Very sad for the athlete and sad for us to watch that happen and her to go through that again. It's very emotional. Next is evidence, so the anatomy. The anatomy of the knee is made up of bones, cartilages, ligaments, tendons, and muscles. The muscles within the knee are the patella, the femur, the tibia, and the fibula, as you can see here, they're labeled. And the ligaments, the main one we're going to be talking about today is the anterior cruciate ligament, which is the ACL. And you can see that, it labels it right there. And then corresponding to that is the posterior cruciate ligament, which lies behind the anterior cruciate ligament. And then there's the medial and lateral collateral ligament. They lie on both sides of the outside of the knee. And then we're going on to cartilage. There are the menisci, which are kind of fat pads that are underneath the femur, so the femur does not go bone to bone with the tibia and cause bone to bone friction because that would be very painful. And there's a tendon that attaches the patella to the tibia. It is called the patellar tendon, and that is needed because the patella is kind of just a floating bone. And then the muscles. The muscles make up the quadriceps, there are 4 of them, and the hamstrings. There are 3 hamstrings in the back of the leg. The next set of evidence that I wanted to support was the role of the ACL and the mechanism of injury. So the role of the ACL within the knee joint is stability. It protects the knee from the tibia translating too far forward, which is the main cause of an ACL tear. And a couple mechanisms of injury which cause that to happen are hyperextension at the knee, so your knee bends too far backwards, a planted foot and a rotational force while you're on a planted foot, and a planted foot and then a blow to the back of the low leg, which means that the tibia could be caused to translate too far forward from the tibia, or from the femur, I'm sorry. A few signs and symptoms when your patient has torn their ACL, they will say that they felt a pop, click, or snap deep within their knee. They'll have deep knee pain. They won't be able to localize where the pain is. They may have trouble putting pressure on their leg or report a sensation of like their knee giving out. There will be bruising and swelling immediately after the injury. They will also have weak manual muscle testing, which is where they have really no strength compared to the other leg, and an antalgic gait, which means that they will limp, and most of the time their knee is flexed forward and they'll be walking on their toes. So next is a little bit of my evidence, and it's more of a question, but it was also stated of why, so I had my question answered. It was, why are women more prone to this injury than men? Well, I found a fact by Austin in 2013 that stated that women are 4 to 6 times more likely to tear their ACL than men. And a few factors of those are because we have a wider set pelvis for bearing children, so it makes our knees align more in a valgus formation, which means our knees kind of curve in compared to our body. So our Q angle is a lot greater than men, so when we do pivot or shift directions, our ACL, like the laxity in it, is greater, so we can tear our ACL. Also, there's a narrower space within the knee joint for our ACL to travel through, so when that tibia translates forward, it's small, so it just tears if it goes too far forward. Also, we have less muscle mass, which causes damage because if our quads are 2 times more stronger than our hamstrings, then it's not going to prevent when we stop our tibia translating forward. It's just going to make it go forward because our quads, which are on the front, are stronger than our hamstrings, which are in the back. And obviously, I stated it already, the greater flexibility. If our ligaments are more lax, then we have a tendency to tear our ACL more because it's giving more than it should. So a little bit more evidence is our evaluation as an athlete trainer. So as an athlete trainer, we do documentation, which considers our SOAP note. Our SOAP note is comprised of subjective, objective, assessment, and plan. Our subjective are the things that we cannot see, so we have to ask, what's your pain like? What increases your pain? What decreases your pain? What did it feel like when it happened? What does it feel like now? Kind of questions like that. When you go to the doctor, what they ask you. And then our objective are the things that we can see. So things like bruising and swelling, and if your knee is flexed and you can't straighten it all the way out, if you're weaker than what you should be. And then our assessment goes on to our diagnosis. We are not doctors or physicians, so we cannot technically diagnose in the United States, but we differential diagnose, which means we can give up to 1 to however many diagnoses that we want to, which gives the doctor an idea of what we think it is. And it's also kind of a second opinion for our athletes too. They get our opinion of what we think it could be, and then the doctors are their second opinion. And then there's the plan. So the plan is patient and clinician-centered outcomes, which means we want to know what you want after you get hurt, like what the things that you want to be able to do within certain amounts of time, the things that you enjoy doing that you'd like to get back to. And then we have our plans, so what we want you to be able to do and what we think you should be able to do after certain times, as well as your return to play. When are you going to be able to get back out on the court? Or if you're an older adult, when are you going to be able to do your laundry again or drive a car? Things like that. And then your treatment and rehab, which fall within your return to play. Your treatment and rehab go on every day, which determines how soon you can get back to doing what you would want to do. Next is evidence. So evidence for imaging is required from healthcare providers to see if and what all structures are damaged during the incident and whether it can be surgical or conservative treatment. So conservative treatment is not surgical at all. You do not require surgery. They just rehab until the pain goes away. So an x-ray is the first type of imaging that will always be done no matter what, because all insurances most of the time cover x-rays. X-rays show up fat, muscle, and bones. So it's mainly used to rule out a fracture. But like I said, insurances do cover this, so it does happen to be a fracture, then it saves the patient 100% of the cost. But if it's an MRI, then if you need an MRI, then you still don't pay anything for the x-ray. So it's not like you're losing any type of money. So next we'll talk about an MRI. MRIs are usually used if you expect a rupture or tear. So if the x-ray does not show anything and we need to figure out more and dig in deeper, then we will go to an MRI. MRIs show up damaged veins, arteries, cartilages, muscles, ligaments, and bones do show up on these as well. A direct sign for a torn ACL is an empty notch, so it'll be like a big black hole within your knee joint in a coronal view, so it's like looking down at all the compartments of your knee, and it'll show like an empty hole where your ACL would be if it was completely torn. So that's the main sign. But by using an MRI over an x-ray, it makes the sensitivity and specificity greater than 90% accurate. Therefore, an ACL shows up on an MRI 94% of the time. Therefore, an MRI is the best way to diagnose a torn ACL. So surgical treatment, there are two types of grafts that you can use, one being an allograft and one being an autograft. An autograft is when they use one of your own specific ligaments. So if there are three types of grafts, so there's a hamstring tendon graft, a quadriceps tendon graft, and a patellar tendon graft. An autograft of one of those three would be them taking your hamstring tendon, your quadriceps tendon, or your patellar tendon. But an allograft is when they use a donor's. So they can use one of those three, but it's not going to be yours. It's going to be a donor graft. There is no specific ligament or tendon to replace that is 100% accurate that you're not going to re-tear. All doctors just do this specifically based on their comfort zone. So there's no guarantee if they use a hamstring graft, you're not going to tear your ACL, or if you use your patellar tendon graft or a donor patellar tendon graft, you're not going to re-tear your ACL again. So it's basically just used on doctor preference, which ones they're more comfortable with doing or which ones they do more often and which ones they see more success rates with. Next is rehab. Our rehab, I chose to take two protocols, which are ACL protocols. After surgery, you go by these until you can get back to your sport or your activities of daily living. The first protocol is the MOON protocol. It usually releases athletes between 3 and 4 months back to their sport or like truck driving or construction working type things. And then another rehab by Michael Duke and Brent Bronze in 2015. Them, on the other hand, they don't get released for 24 months or after, possibly. The things that are different from the two is the MOON protocol requires a prehab plan, which means they do rehab before they go into surgery, so the surgeon can bend and flex their knee as much as possible. And Brent and Michael's version, they do not have prehab goals. They do not start rehab until after the surgery is completed. Also, in the MOON protocol, they brace for 24 hours afterwards, and then they don't have to wear the brace ever again. It's part of getting them out quicker and comfortable to their environment again. But Brent and Michael think that they should have the brace on between 2 and 4 weeks after their surgery. And they're the same for full weight bearing. They basically can full weight bear for up to 2 weeks after surgery, so they're on crutches for 2 weeks. And then after that, they can be full weight bearing. And another difference is the MOON protocol goes off of functional. So you cannot move on to the next step until you can complete the functional task that you were supposed to do. But if you go to Michael and Brent, you have to wait the week that they want you to be at a certain thing, a certain functional-based movement. You have to wait weeks for that. You don't have to wait until you're completing the functional movement. You have to wait until the week is up, and then you move on to the next week of what they think you should be able to do. So it's based on weeks, and the Moon Protocol is based on your function, what you're capable of doing at the moment. And then return to play is based on if your functional movements are adequate and you can return to play the sport that you were injured in, or another sport that you're just returning back to the season. If you can complete the sport movement, and if you can take contact. If you cannot take contact, then you cannot return to play. And Michael and Brent, they base theirs on how many weeks out of surgery you are until they release you to return to sports. So the Michael and Brent's return to play is 24 weeks or after, and the Moon Protocol is between 17 and 20 weeks, which is very quick. So prevention. Why prevent? I found a few statistics that kind of shocked me when I first was doing this research. So prevention is a very big thing, I believe. So an estimate of 200,000 ACLs are torn in the U.S. every year, and at least 90% of those 200,000 choose to go under and do surgery, and then 50% of those 90% fail to perform like they did before they were injured. So they never return to their same self before. They can't get back to their pace. They can't beat out another teammate like before. If they could do that, they can't do that now. And then the beginning statement that I said was very surprising to me, that 11% of reconstructed ACLs do not last longer than 15 years. So you're getting another surgery after 15 years, or a knee reconstruction, which is worse, after 15 years. And then that 1/3 of athletes that return to their sport re-tear their ACL in 30% within the first 20 athletic events. So first off, with preventing, there are ways to prevent ACL tears. There's prevention programs, and there's this scoring system called the land and error scoring system. It teaches you how to land and jump properly. So preventing, there are 5 stages during preventative programs. The first one is informing the mechanism of injury for the patient. So telling them how you could tear your ACL and how you can prevent tearing your ACL. That is always the first step in programs. This is how you tear your ACL, and then the things that we are going to do within this program is how you can prevent tearing your ACL. The second thing is jumping exercises. So teaching them how to land and jump and take off from a jump properly is one of the keys, because you can tear your ACL just jumping up and leaving the floor. And then second is proprioception. So proprioception is balance. And if they have balance, then they should be able to have a stronger muscle mass, which can prevent the ACL tear in the first place. Strength training, which is obviously like what I just said. If they have more muscle mass, then obviously they can prevent that tear. And then running and flexibility. So running does help them within the progression, and then their flexibility, if their muscle is not tight, then the likelihood of it tearing is slim to none. So an estimate of 1 in 3,500 ACL tears occur in high school sports that involve a ball. So volleyball, basketball, softball, baseball, the things that require like pivoting at the knee with that planted foot and that turn, you are more likely to tear your ACL. So it doesn't surprise me that half of the sports have balls. And then you can reduce the occurrence of these knee injuries up to 27%, and tears, ACL tears, up to 51%. So you can reduce just general knee injuries by 27% by doing these prevention programs, and then ACL tears by 51% by doing them. And that study was by Mel and his colleagues in 2017 that stated that. Finally, my limitations for this study is that there was no research on how to prevent a second tear. There were only suggestions on preventative programs that you could do and for doctor checkups. It just never really stated these are the things that you can do to prevent an ACL tear. And that's why I wanted to do this research to kind of further if there is a possibility that there could be a preventative thing for a second tear. Lastly, my conclusion, after reviewing multiple scholarly journals and academic articles, 1/3 of female athletes do tend to re-tear their ACL after returning to play. This is due to them being released too early from rehab, being hesitant when they return to play, so scared to get back on the court or on the field or perform like they used to perform. It's kind of scary sometimes, and returning to their poor mechanisms. So if they don't do a preventative program and learn how to do all the things properly, then they do have a chance to re-tear their ACL because they're doing the thing that they did before to tear their ACL. They never learned how to fix it. So, like I said, in the limitation, there is no evidence that suggests a specific graft to reassure you of not re-tearing your ACL, and specific grafts are chosen upon by your doctor in their comfort zone on what they're more comfortable with when they do your surgery. And lastly, filling the gap with this ACL research could potentially help the medical field advance the surgery due to it being so widespread. The research is never going to stop. It's only going to grow. So hopefully one day we can prevent ACL tears and just even re-tears in general. Thank you. This is where we're excited.